Three, two, one. We are live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas, I welcome you all for the Synergy Club webinar, episode 4, on the topic, the cool advantage, how freeze all transforms IVF. Before starting the webinar, we will have live lightning.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is National Executive Member, ISAR. She is Founder President of ISOPAP Chapter Bhopal. She is Vice President of Bhopal Obstetrics and Gynec Society. She is Vice President of Bhopal Menopause Society. She is National Coordinator of Foxy Infertility Committee. She is also the convener of ISAR Perfection Series, Foxy Symbiosis Series, and the President of the Synergy Club webinar. Over to Dr. Monica Singh.
Thank you, Dr. Vishal. I think there is some problem with the pixels on the screen. Can the support team make the screen clearer for us? I think it's hazy. Some problem with the pixelation.
Madam, here it is clear.
No, yeah, now it is clear. Can you put it now full screen? Yeah, now it's perfect. So I welcome everyone pre-Diwali to the Synergy Academic Club. Today is a very special episode because it's a cool episode. The cool advantage of how freeze all or vitrification has transformed IVF from the time we stepped into this field. I think Dr. Viren Shah was there much before us, but when we came, vitrification was not there. We had to order this cryo machine from outside, from Australia. And imagine the day I got it, the very next month, vitrification came. So vitrification has basically transformed IVF, and this word is derived from the Latin word vitrum, and vitrum means glass. So basically what happens in vitrification, you learn from the experts, but I just want to tell you in plain English, a liquid turns into a glass-like clear state without forming ice crystals. So this technology is so simple and so effective that it has minimized DNA damage to the cells. It has improved survival rates of the thawed embryos and gametes. It has increased pregnancy rates. It has made life very convenient for the IVF specialists. It has given us the option of tremendous amount of fertility preservation to be done successfully. And it has also given us the option of doing elective single embryo transfers. So the rest is all now in the hands of my speakers, my experts. And we have with us our chief guest, Dr. Viren Shah, past chairperson ISAR Embryology, who is with us, a very, very senior embryologist from Indore. We have a special guest, special subject expert and a very dear friend from Pune, Dr. Ashwini Kale, who is the National Executive Member Embryologist of ISAR. We have our guests of honor, our very own dear Dr. Kanti Bansal ma'am from Ahmedabad, Director, Safal Fertility Foundation, Ahmedabad. And we have with us our guest of honor, Dr. Nirmal Bhasin, who is chairperson of ISAR Chandigarh chapter. And she held a very beautiful conference just recently. Our program consists of 3 talks. We have tried to coordinate the talks in such a way that the clinician topics, they merge seamlessly into the embryology portion of the webinar. So we start with Dr. Kalyani Srimali, who has been so kind to join us, though she is traveling. So she'll be talking on optimizing outcomes, when and why to choose freeze all in IVF. So basically when, why is by Dr. Kalyani. And next we come to the freeze all strategy, the actually clinician, the guidelines, and how does it revolutionize our success rates in IVF by none other than Dr. Ritu Hinduja from Mumbai. And lastly, we have the vitrification in IVF, the scene in the lab and the science behind freeze-all by Dr. Rahul Salve. So without wasting much time, I would like to honor and welcome our chief guest, Dr. Viren Shah, sir. Can I have Sir's CV? Dr. Viren Shah needs no introduction from everyone who is in the field of IVF across India and even abroad. He's the first embryologist of Central India who worked with the legendary Dr. Gada, Dr. Dheeraj Gada sir, and has trained so many embryologists, has worked in so many centers, experience of more than 3 decades. Sir has trained in Singapore in ICSI co-culture methods, which that time were very new. He is also working as a freelancer embryologist all over India and abroad. He is still working, gives a lot of time to Gada IVF and HD Care Indore. His son is a gynecologist. His daughter-in-law is a gynecologist. His daughter is an embryologist. And he is the director of Shah Pathology Lab and Gamete Bank Indore. Sir, the stage is all yours. We would like to have words of blessings from you.
Thank you, Monica, for inviting me in your Synergy Club. The topic is a vitrification. You already explained everything about the vitrification, but vitrification revolutionize the fertility, preservation, and IVF, offering hope and flexibility of individual and couples. After vitrification, they enhance the success rate in IVF. We rarely know about the phase through the OHSS, because the control the OHSS after starting the vitrification. The main importance of the vitrification is the use in age-related decline in fertility, medical condition affecting fertility, cancer treatment, fertility balancing, family balancing, and evolution egg freezing. So now over to thanks for the inviting me, and I also thanks to your special guest, honorable guest, program coordinators, and mainly our good speakers. Thank you very much.
Thank you so much, Viren sir. Thank you for joining us and thank you for imparting the words of wisdom. And now it's my very great privilege to introduce Dr. Ashwini Kale in front of the August gathering. Dr. Ashwini Kale is the chief embryologist at Asha Kiran Hospital and Asha IVF Center, Pune, as well as the branches in Arunachal Pradesh and Hyderabad. I think Madam is visiting Middle East also for her cases. She has been the Secretary, Pune Obs-Gynae Society, Treasurer, Maharashtra Chapter of ISAR. She is the Managing Committee Member, Embryology of ISAR, Managing Committee Member of MSR, Chairperson of AMOG's YTP Committee in 21 to 23, Zonal Coordinator AMOG's 18 to 20, Peer Reviewer of Jogi till date, and has been awarded the Foxy Sun IAEC Traveling Fellowship in 21 and Foxy Shanti Yadav Award in 22. Thank you, Ashwini, for joining us. And we would like to have a few words from you, please.
Thank you so much, Monica Madam, for the kind invitation. And I must really congratulate you for continuing this Synergy series non-stop with amazing topics, which are very useful for the day-to-day clinician and the embryologist also. I mean, for over past 2 years now, I am seeing you continuously, not even a single webinar that you have missed till date. And I really thank Amit Patki sir, ISAR, for starting this series. And you have chosen such a good topic of vitrification now, as sir rightly said, that we have traversed so much in this vitrification. And it is only because of this that the lives of so many clinicians and embryologists have become easy, wherein we can actually plan and make the treatment tailor-made for each and every one of our patients and optimize their results. Now we are even moving to the world of automatic vitrification, which has come up in a very big way now. And the vitrification protocols literally have changed from 12 and 10 minutes to 1 minute now. So we have such good media coming up. So it will be really a pleasure hearing my two very good friends, Kalyani and Ritu, speak on the clinical topics, and also Dr. Rahul speak on the embryological topic. Thank you once again, Monica Madam.
Thank you, Dr. Ashwini. Those were really, and I've listened to listen you talking about vitrification very recently. You yourself are a very great speaker and you spoke on AI that time.
Right.
So now it is time to welcome and welcome our lovely guests of honor, Dr. Kanti Bansal ma'am, who is there with us since the beginning of the program, and Dr. Nirmal Bhasin ma'am, who will join very soon. Dr. Kanti Bansal is like, she is like a flower. Like wherever she goes, I think she spreads her beauty and her fragrance. So, madam, this is my impression of you.
Thank
I
you.
would like to introduce you now formally as the Medical Director, Reprosci Biosciences, Bengaluru, Director of Safal Fertility Foundation, Ahmedabad, pioneer and very senior in the field of assisted reproduction in India and Gujarat, one of the pioneering individuals in Gujarat who established and trained hundreds of people in IVF, pioneer in AI, virtual reality and haptics and ART simulators. Madam has been awarded RCOG Distinguished Service Medal in 2020. She specializes in the management and very, very intricate counseling of infertile couples. She's a very sweet-spoken person. I know how she talks to her patients. She is also very much interested in PCOS, endometriosis, and women's healthcare. Madam has published 12 books on PCO, endometriosis, infertility, and ART, which are used as reference by many medical students and practicing ART clinicians. She is a guide to PhD students, a visiting faculty at Gujarat University, and has successfully trained more than 2,000 gynecs in PCO, endometriosis, infertility management, and ART. Madam, we are waiting to hear you, and we are really grateful that you could spare your time.
Thank you so much. Really, you have made my day. Dear friends, at the outset, I would like to congratulate Dr. Monica Singh. She's the convener for this fantastic creation of Synergy Club, and as Ashwini already told, she's continuing to do it from 2 years, and I see week after week, it's so difficult for us to manage all these things. What happens anytime whenever we start something, we stop at some point, but she is really good at continuing the this is known as continuing education, medical education, very hard working, and I love her approach in managing her work. It's really awesome. And let's speak about this episode 4 of Synergy Club. The title itself is mesmerizing. The cool advantage, how Freesolve transforms IVF. I really think it is true, because when we started way back in 1996 onwards, we never thought that freezing will be there. And then after some years, the slow freezing came, and then it was not very, very IVF specialist friendly, because it was very expensive and it was difficult to avail. It went on for several years, and then we had this vitrification, and vitrification, though slow freezing was easier for the embryologist to do, but the vitrification, but it was very expensive. The apparatus itself was very expensive, but the vitrification, it is not very expensive, but the embryologist technique has to be really good, in the meaning they have to be very fast in their work. This is the main difference between slow freezing and vitrification. I'm so happy, Monica, you've taken all the 3 important topics, and excellent speakers, and I think this subject itself is very cool, at the same time very hot, and congratulations for managing it so beautifully. And I think almost everyone you have invited is here. I really wish all of you a very happy Diwali, and my blessings are there, Monica, and all the other people who are younger to me in age. And God bless you all, and have a successful year ahead. Thank you.
Thank you. Thank you so much, Kanti ma'am. And now Ritu is here. I must tell everyone that this topic is the brainchild of Dr. Ritu Hinduja. So when we thought of the topic, I always give the opportunity to all my friends that what is the best caption possible. So Ritu's caption hit the mark, and we kept the title of our webinar as the cool advantage. So thank you, Ritu, for that.
Thank
And
you, ma'am.
now Dr. Nirmal has joined us. She is our guest of honor, along with Kanti ma'am. Welcome, Dr. Nirmal, who is not only a very dear friend, colleague, and senior mentor. She is director, clinical embryologist, and founder of Janani Fertility Center and MD from Minsk State Medical Institute, Belarus. She is a member of all the prominent institutions, organizations dealing with ART in India, ISAR, IFS, ACE, as well as active in IMA Chandigarh and COGS Chandigarh. We recently participated in a wonderful conference at Chandigarh of ISAR Embryology, and she's currently holding the post of Chair ISAR Chandigarh Chapter, Chairperson of Mission Pink Health of IMA, has an experience of more than 20 years in ART, presented papers in various national and international conferences, and published papers in various journals. And she has pioneered the surrogacy program in the Chandigarh, Tri-City, and Punjab region. We are so honored and happy to have you, Nirmal ma'am. And now the stage is all yours to impart your blessings.
Thank you. I'm sorry I'm not coming on video. I just returned from the doctor and I'm in real bad shape. So basically, Monica, I have known you for I think more than 15 years. And the passion and the dynamism, the dynamic personality of yours for academics is really commendable. I have seen you grow and blossom and flourish, and may God bless you always. And the topic, yes, for today is very interesting. It is also very close to my heart. Being an embryologist, being a clinician first, and then I embarked on the journey of embryology in the year 2000. And the mesmerizing fact, the mesmerizing art of embryology has even molded me into a different human being. And vitrification, what I understand today as of now, maybe we cannot see the future so soon. We may not be there to see it, but yes, we are already on that path. And at times I feel that we are heading towards immortality by freezing cells, maybe organs, maybe, I don't know where science is going to take us, but yes, we have to keep moving. We have to keep doing our best, and God bless us all. And Ritu, waiting to hear you.
Thank you, ma'am. Ma'am, I hope you're feeling well. I mean, you just said you came back from the doctor.
Yeah,
so
I underwent a knee replacement 15 days ago. So
Take care, ma'am.
it's pretty painful.
I can only imagine.
The
But
second
yes,
one,
that will give a better life, I'm sure.
I know. So, ma'am, this is the second knee you got
No,
replaced?
only one.
Okay.
But I
Yeah.
really admire you, Dr. Nimal, because even after such a short period after operation, that to knee joint replacement, you are here with us. That's commendable, really.
I'm missing my clinic. I'm missing all my colleagues already.
Yeah, I can understand.
But ma'am, you will be soon working with double speed now.
Yes.
Your knee
And
is
I'll
so-
come to Bhopal. I'm coming to Bhopal to meet you.
Oh, wow. Great, great. We have a blast. Thank you, ma'am. So now,
Thank you.
ma'am.
yeah, thank you so much, ma'am. And now I would like
Thank you.
give due respect and lot of love to my 3 program coordinators who hold it together for me and who take it forward every time wherever I need something, they are always there. I have Dr. Neetu Mishra, who is Associate Professor OBGY from AIIMS Bhopal. We have Dr. Purva Bhatkur, who is Assistant Professor from Gandhi Medical College Bhopal, and Nandini Singh Bhati, again Assistant Professor from GMC Bhopal. So thank you so much, all of you, for, keeping Synergy alive and synergized. And over to Neetu to start the first talk.
Good evening, everyone.
Acha, Purva,
So,
doing it,
yes,
Purva?
ma'am, I am.
Okay,
Yes.
okay, right.
For session 1, optimizing outcomes when and why to choose freeze all in IVF. I invite Dr. Kalyani Shumali, ma'am. For this, chairing the session, I invite Dr. Manjushri Boom, ma'am, Dr. Namita Kotia, ma'am, Dr. Dhwani Rulekar. Dr. Manjushri Boom, ma'am, madam is presently Specialist Reproductive Medicine, Amravati. Madam is being awardee of Vigyan Vardhan Award. Best Poster Paper Award, and many more awards like Wonder Foxian Award, Star Award, Foxy. Madam has, to her credit, various publications in various books like Adolescent Health and Sex Education, published various papers, and present and in past she is organizing secretary FEMCON 18. In that conference, instrument launch for EASE ET IUI set was launched in this conference. We welcome you, ma'am.
Thank you
Next
so
we
much.
have-
Thank you so much.
Next, we have Dr. Namita Kotia ma'am. Namita Kotia ma'am is presently a consultant fertility IVF specialist at Cocoon Hospital, Jaipur. She has presented various publications in national and state level and recipient of various awards like Best Paper Award, Innate Health Care Award, Rajasthan Health Excellence Award, JMA Award. We welcome you, ma'am, to chair this session.
Thank you so much.
Thank you, ma'am. Next, we have Dr. Dhwani Rolikar, ma'am. Madam is presently Secretary Valsad, Obstetric Gynecology Society. She is consultant and endoscopic surgeon at Yogini Hospital, Valsad, Gujarat, and has held various posts in Valsad, Gujarat Obstetric Society. And she has been contributing various publications in books like Modern Approaches in Recent Procedures in Obstetric Gynae and articles. She is a very active participant in various conferences. We welcome you, ma'am.
Thank you so much. Thank you, Monica ma'am.
Now I hand over the session to the chairpersons to introduce our speaker. Over to you,
Excellent
chairperson.
evening to one and all. Excellent evening to one and all. It's my proud pleasure to be associated with Synergy and especially with Singh ma'am. She's a very close friend of mine. And thank you, ma'am, for giving me this opportunity to be a part of this program. And here we present today evening a very excellent speaker, Dr. Kalyani Srimali ma'am. She is a senior consultant and reproductive medicine consultant at Nova IVF Indore. She has received formal training in field of reproductive medicine from NHS London, Germany, Mumbai, and ICOG Mumbai, and she is dedicated infertility specialist with a experience of almost 11 years, and she has been trained in fertility enhancing endoscopic surgeries under Dr. Hafiz Rahman, and she has been awardee of MOGS Shantabai Gulabchand Traveling Fellowship Award 13-14. Recently has been awarded at Foxy Vasant Ben awardee, and I'll need a screen, please. Yes, and recently has been awarded as, sorry, screen is moving a lot. Yes. Actually, screen is moving.
Ma'am, I think the
What's the problem? Support? What's the problem? Can we have the CV again? Kalyani CV? I'm sorry for that, Dr. Manjushri.
No, ma'am. It's a technical hitch. So recently she has been awarded as Foxy Vasant Ben Award 16-17. She's member of Foxy Endocrinology and YTP Committee, executive member of MPSR. She has been authorized many chapters and also to her credit many publication, and she's reviewer in Journal of Obstetric and Gynecology India. And so we present before you Dr. Kalyani Srimali, and she's going to speak on optimizing outcomes when and why to choose freeze all in IVF. Ma'am, stage or the platform is all yours and we are eager to hear you. Dr. Srimali, please.
Thank you so much.
Kalyani, do you want me to share your slides?
Yeah, please do, because the internet is very unstable here.
Can you see it?
No, Ritu. Yeah, now it's visible.
Okay.
Yeah. Thank you, Dr. Monica ma'am, and thank you, Ritu, for inviting me for this today's program. Firstly, I would like to start by apologizing because I'm in train, so I don't know if my network would be, available throughout my presentation. But I have my backup ready with Ritu. So if I get lost anywhere, she'll be able to take up with the presentation out there. Thank you, Synergy Tim, for having us and a fantabulous program going on without any hitch. Thank you, Manjushri ma'am, and all my respected chairpersons who are here for introducing me and being here. And for Dr. Dhwani out there, Dhwani, I'm from Vapi. So hello.
Nice to
Okay.
meet you, ma'am.
Yeah, same here, same here. Say hello to Yogini ma'am.
Definitely.
Yeah. So let's begin with today's topic with the first topic. Can we have the next slide, please, Ritu? Yeah. Optimizing outcomes, when and why to choose freeze all in IVF. So, like we introduced, it's the world of ice. So we can't forget the magical Broadway, the Frozen, wherein we see these small, tissues or cells or anything which is getting converted into ice. And that's the whole idea behind the vitrification. So what is vitrification? Like Dr. Monica ma'am just mentioned. Next slide, please. Vitrification, that's the solidification of the liquids without crystallization. This comprises a glassy state, as the system is amorphous, lacks organized structure, but possesses the mechanical and physical properties of a solid. Next, please. So the first baby which was born through the frozen embryos was Zoe Leland, who was born in Melbourne in March 28, 1984. And since then, vitrification of embryos has become an integral part of our ART practice, and it does has many benefits to offer. However, still an ongoing debate if the patient should be offered freeze all only cycles or fresh embryo transfer. So let's ponder upon which road we need to take and why all freeze is important and how we can optimize our ART success through it. Next. So why are we discussing the reason behind the all freeze? Is it because the implantation rate? Is it because of the decentralization? Is it the placentation? And then ultimately the live birth rate. Next, please. So if we go through the entire series of this, the paper, which was published by Dr. Mohan Kamath, Dr. Sukarna, and the objective was to understand the perinatal outcomes after stimulated versus the natural IVF cycle. So let's understand why we need the all freeze. The first and the foremost is if we look into the live birth rate. So let's compare if the preterm birth rate less than 37 weeks. Was it higher in the cases where there was a stimulated IVF, or was it higher when we did a natural or modified natural IVF? So if we look into the subgroups, the natural cycle IVF and the modified cycle, and if we look into the right side, the risk ratio, so it is clearly mentioned that, the live birth rate favors with more of the natural or the modified natural IVF, where we are seeing less part of the preterm births compared to the natural stimulated cycles. Next, please. So when we compare again with a low birth weight, that is less than 2.5 kgs, the cycles which favors the stimulated cycles, they are the cases where we are seeing that, we are having the low birth weight babies more compared to the natural cycle or the modified natural cycle IVF. So of course, at term, good weight babies are more in favor of the natural or the modified natural IVF cycles. Next, please. Again, if we compare the oocyte number and the perinatal outcomes following an IVF, if we see the chart which shows the preterm, which shows the low birth weight, early preterm, and the very low birth, the red arrow is the place wherein when we have the oocyte numbers more than 20, the preterm, low birth, and the very low birth, they all drastically increase. So that means that if the oocyte numbers are on the higher side in cases of the stimulated IVF cycles, and where we are aiming that we get, maximum number of oocyte retrieved, we are ending up with mental complications. Next, please. So with the increased risk of term birth and low birth weight with very high number of women for the IVF, this is the study which was analyzed by 1968 Singleton live birth outcome, and it clearly shows that more than 20 oocyte will increase this risk. Next, please. The next slide, please. Yeah. Stimulated IVF cycle, and when we are planning a fresh embryo cycle, this itself, this paper is showing that when there is a supraphysiological estradiol, it is an independent predictor of low transfers. No, the previous slide, please. Yeah. So if we look into the E2 levels done on the day of the HCG trigger, whenever we have the E2 levels more than 2000 or more than 2500, and of course, if it goes beyond 4000, the chances of having the low birth weight, even at the fresh term and full term singletons, were on the lower side in the fresh embryo transfers. Next, please. And hence, association between the number of the eggs and live birth in the IVF treatment, an analysis of almost 4,135 treatment cycles was done, and it shows that as soon as the number of the oocyte keeps on increasing at the time of the retrieval, there's a decline in the live birth rate with more than 20 oocytes following a fresh embryo transfer. The endometrial receptivity Ritu, the next slide, please. So coming to the first point justified, that when we are doing the fresh embryo transfers, and if there is a decrease in the live birth rate, embryo is not guilty. It's basically the endometrial receptivity which is getting affected, stimulation, and that is resulting in the decrease in the live birth rate. And of course, the perinatal outcomes, as we have already discussed in the fresh embryo transfer, much bigger problems by having the low birth weight. Next, please. So coming to the second point, why the endometrial receptivity? So of course, when you're stimulating the patients in the fresh embryo transfer, or when we are stimulating, the hormonal levels are on the higher side, which leads to the endometrial advancement and peri-implantation modifications which happens. Now coming back to the next slide, please.
What are you doing now?
So now let's start comparing with all this strategy to optimize the success. Ritu, next slide. Yeah. So the first article which came across was the fresh versus frozen embryos in cases of PCODs. Next, please. This was published by Z in 2016, wherein we have compared the fresh versus the freeze all RCTs in the PCOS. Sorry, the next slide, please. Yeah. So here, when we have compared, there were almost 746 patients enrolled for the frozen embryo transfer and almost 762 patients enrolled for the fresh embryo transfers. And there was the next slide. So when the primary outcome, that is the live birth, was compared, so we had almost 368 patients which were pregnant through the frozen embryo transfer, that's the live birth rate, and through the fresh embryo only 320, which shows that the rate ratio, that is the RR ratio, was on the favorable side for the frozen embryo transfers. That's almost 1.17. Next, please. Coming to the second part of the outcome, that's the pregnancy loss, which is again important, which was divided into the biochemical pregnancy and into the clinical pregnancies in the first trimester and second trimester. So we did see that the pregnancy losses were higher on the fresh embryo compared to the frozen embryo transfer. Compared to the live birth rate, we have already discussed that it was on the higher side when we had the freeze all cycles, and the miscarriages were on the lower side when we had the freeze all cycles. Next, please. There was a good study which came out by Coates et al., and which was published in Fertile and Studied in 2017, showing optimal euploid embryo transfer strategy, fresh versus frozen, after PGD testing with the NGS sequences. So this was an RCT again. Next, please. It showed that when the PGS was done or the PGTA was done on day 5 of the embryo biopsy was taken, the ongoing pregnancy rates again was on the higher side when there was a freeze-all cycle compared to the fresh cycle, almost 62.6% compared to the 40.9%. And the live birth rate was on statistically higher side, that's almost 61.5% compared to 39.8% in the fresh transfers. Next, please. In the fresh versus freeze-all, when we had a D3 transfer and a fresh embryo transfer was planned only when the progesterone level was 1.5%. Again, the logistic regression showed that the freeze-all had a better chance of having a live birth and an ongoing pregnancy rate, and even the implantation rate at the particular. This was published in Fertile Sterile in 2015. Next, please. So we compared the live birth rate, we compared the PGT, we compared the miscarriages. So now there was this interesting study again by Roque et al. Published in Nature 2016, which showed that was there any increase in the ectopic pregnancy rate when we did the fresh embryo transfer or when we did the FET cycles. So in the last 20 years, almost 929,000 pregnancies were studied, and fresh versus the frozen embryo transfers were compared. Next, please. And it clearly showed that the frozen embryo transfer had lesser amount of ectopic pregnancies than the fresh transfer. So if you see into the figure, it's almost just 21,916 ectopic in the frozen and almost 48,955 in the cases of the fresh embryo transfers. Next, please. The previous slide was showing with the cleavage stage, and this is with the blastocyst stage, which showed almost 179,000 pregnancies, and we had 90,000 instances when we had the fresh transfers of resulting in the ectopic pregnancy. Next. When we compare the preterm birth rate, again, in the first one is the frozen subgroup. So we had almost 79,113 pregnancies resulting into preterm labor through the frozen transfers, whereas in the fresh we had almost 140,000. So again, the odds ratio is in favor of the frozen embryo transfer compared to the in favor of fresh, which results in the preterm labor. The next complication, what we are talking about, is for the small for gestation age. In the next slide, please. Out of those 9 lakh pregnancies which were studied, almost 104,180 pregnancies were compared for the small for gestational age amongst the fresh and in the frozen, wherein it showed that 49,000 patients delivered through the frozen transfer had a small for gestational age compared to the 55,000 in the fresh. Again, prove on the point that it favors the frozen embryo transfer in terms of the perinatal outcome. Next, please. Again, one more perinatal outcome, that's the low birth weight, shows in favor that fresh. A huge review data was collected for the Cochrane, which showed that fresh versus frozen embryo transfers in assisted reproduction by Wong K.M. in Cochrane 2017. Next, please. The first outcome that we discussed is the live birth rate. Again, it was divided into cleavage stage transfer and the blastocyst stage transfer. If you look into the right side, the odds ratio, it clearly shows that the live birth rate in the cleavage stage was in favor of the freeze-all cycles, having a better live birth rate compared to the fresh transfer. In the blastocyst stage, they had a similar result. It had 130 patients delivered through a live birth rate in the frozen and around 129 in the cases of the conventional IVF. So it's in the same statistically non-significant. Next, please. In cases of the ovarian hyperstimulation, we all know that we are all stepping into the generation or the era where we are declaring ourselves as the OHSS free clinic. So of course, we all are in favor of the freeze all technologies and using the frozen embryo transfers later in cases of the PCOD patient or wherever we suspect that there's an hyperstimulation. So no competition out here or no fight around here. In terms of the birth weight, again, the Cochrane did the review and it showed that the birth rate of the singletons were in the favor of the freeze all cycles compared to the case of fresh transfers. Next, please. So when this review was done, it had included 4 RCTs. It showed the clinical heterogeneity was observed between the studies, but when the pulled together studies included the normal responders, hyper responders, and those with the PCOs. So when we speak about the all three strategies, normally whatever evidence comes out, they're always in the favor that whenever we have the patient of hyper responder, it's a rule of thumb that we are going to go for the all threes. But still, people have not been agreeing on the cases of the normal responders or in the cases of the low responder that should we be going ahead and planning the all three strategies for them. So this Cochrane review had pulled together the studies which included all of the responders, that's the normal, hyper, and as well as the low responders. But yes, further RCTs have been published now proving that it's beneficial for all the cases. Next, please. Coming to, like I said, that there are studies which shows that, in cases of high responders, they have to go ahead and do the all three cycles, but maybe not in cases of intermediate and the low responders. So this is the comparison of the live birth rate and the single birth weight in cases of all the three. The first is that we have retrieved oocytes between 1 to 5, which shows that yes, all threes does give us a higher live birth rate. It also gives us the birth weight has similar to the fresh transfers. The second pie diagram shows that oocyte number between 6 and 14, a slight increase in the live birth. And the third is where we have retrieved more than there is the birth weight. Next, please. Again, higher probability of live birth rate in the high responders, but probably not in the normal responders after the first frozen embryo transfer in a freeze-only cycle strategies compared to the fresh embryo transfer. This was the study published in Human Reproduction in 2019. Next, please. So when we discuss about the fresh versus the frozen, so what is the main interest? So any IVF cycle aims on having a live birth rate and reducing the perinatal complications. So yes, if it is associated with the lower risk of preterm birth, it also reduces the low birth weight babies and the smalls for gestational age baby. But yes, it did also have a little bit of higher risk of hypertensive disorders, high birth weight, and the large for gestational age babies. But looking into the current scenarios where, the people are conceiving at the later age of their maternal age, beyond 38 or beyond 40, we all know that it is anyways going to increase the chances of having the PIH or pregnancy-induced hypertension. So having a healthy baby at the correct time at the term is the most favored priority or a favored outcome for the baby, and hence the frozen embryo transfer will always give us a better obstetric and perinatal outcome compared to the fresh embryo transfer. Next, please. So in conclusion, normal responders, comparable live birth rate with the fresh transfer versus the FET following the cleavage stage transfer. Decline in the live birth rate, higher risk for preterm and low birth weight babies with the high oocyte numbers in the fresh cycles. Higher live birth rate with the frozen compared to the fresh transfer in the women with PCOS and high responders. Significant reduction in the OHSS with the FET. Low birth rate with fresh versus the FET in the context of 2:0 PGT. Next, please. Higher risk of low birth weight following the fresh transfers, higher risk of macrosomia following the frozen transfer. Consequences, but yes, they can be dealt with. Clinical scenario, patient burden, cost effectiveness to be considered when deciding the first line of treatment in cases of poor responders, normal responders, and high responders. Next, please. So strategies give you the direction. Technology lights the way. So having the newest technology of all freeze with the improved versions of vitrification, and like how Dr. Ashwini just mentioned that, we are aiming at the AI now for the vitrification, reducing the timing in the vitrification. So I think it does justify having a good maternal and the perinatal outcome with a good increase in the percentage of the live birth rate. And hence all freeze is the strategy to move forward for our patient to improve the ART outcome, aiming at having that healthy live birth rate of the baby. Thank you so much.
Do the chairpersons want to comment on the talk? Manjushri ma'am, Dr. Namita, and Dr. Dhwani.
Dr. Kalyani, thank you so much for such a wonderful presentation. I have one query. If you're planning a freeze all strategy, so would you go in for this? What experience you have for this PPOS protocol? When you plan a
So
freeze
yes, we
all-
have started. Yeah. So normally what happens is in the IVF center, nowadays we have got so many protocols that we have been using so that it becomes patient friendly, and patient don't have to travel too much also for us to avoid the traveling and all. So yes, PPOS is something that we have started doing when the patients have a little bit of problem in traveling, but still we do prefer if they are under monitoring with us. PPOs have given us good success rates with good embryos that we are getting in the blastocyst stage. And because nowadays patients read about it and patients have got the awareness that, the frozen embryo transfer gives us a better pregnancy rate compared to the fresh. So counseling the patients for the frozen embryo transfer is not very difficult. And giving in the PPOS protocol is also not very difficult. It's only the selection of the patient. Because like me practicing in Indore, we get a lot of peripheral patients who may skip one day of progesterone and land up in having a premature luteinization. So in such patients, I would still prefer the conventional IVF with the antagonist protocol. But patients who are educated, patients who can understand and who want to reduce their injection, usage, are the people in whom we can plan on giving the PPOS protocols. Or for the donor cycles, we can give the PPOS protocols. So yes, it's a very good strategy to go ahead.
Also in diminished ovarian reserve, I think we can go in for this protocol because there is prolonged length of stimulation. So, and we have to in any case
Right.
freeze in these patients. So
Right.
definitely
Right.
it's a good protocol. And we have to
Yeah.
individualize,
Yeah.
obviously.
So
But as such,
exactly. So like speaking about the immunization in the poor ovarian patients, normally what we prefer is doing a flexible protocol of antagonist so that वो fixed protocol पे हम day 6 पे antag नहीं add करते हैं. We wait till that follicle becomes around 14, 15 and then start adding up the antagonist. So even if it's a slow protocol, we know when to add the antagonist. The only thing is we prefer doing much better monitoring in case of poor ovarian reserve or the poor responder, because these are the patients who may sometimes end up having premature ovulation. So it's better not to, give them something where they are not required to monitor. So monitoring in such patients is the most important thing once they hit that 14, 15 mm of the follicles.
So I wanted to ask a question, Kalyani. Do you freeze your embryos in poor responders, especially Poseidon 2, Poseidon 4, elderly? That is
So,
the
ma'am, when we have, so ma'am, two parts to it. One is the poor responders are the ones who are not responding and, they're having very slow growth. So probably in those patients, I know that the oocyte quality is going to be on the poor side. I do plan on doing a fresh embryo transfer for them. At least start with the luteal support, look into how the blastocysts are progressing, and then, decide about doing the fresh embryo transfer or deciding on the frozen embryo transfer. And of course, depending upon the progesterone levels as well. When we speak about the Poseidon 4, where the age of the female is more than 35 and we have a poor ovarian reserve or a poor responder, probably I'll be doing an all-free cycle because I must have already counseled the patient for doing a PGT case with me, because I know somewhere or the other, the chances of having an aneuploid embryo would be higher for them. But if we just speak about, removing all the PGT and all, my first preference will always be if I can cryopool the embryos or if I can give a patient a better chance with that single embryo, then in that case, I would like to go ahead and freeze the embryos and then go with the frozen embryo transfer or plan one more IVF cycle for her.
Okay, what about you, Ritu? You would prefer a cryo pool or would you like to go for a fresh transfer, Poseidon 4?
So, ma'am, I actually kind of agree with Dr. Namita here. I like doing PPOS protocol in women with poor ovarian reserve. It has been giving me really good results. I have had this conversation with a lot of people across the world, across the globe, doing PPOS, and they also have been having very good results with PPOS protocols where the number of follicles recruited plus the number of M2s also increases. So once I'm doing a PPS protocol, I am freezing all definitely. So yes.
Okay, so PPOS and freeze all for Poseidon 4 for both of you.
Absolutely, absolutely, yes.
Okay, right. Thank you. Thank you for a great talk, Kalyani. And I think now Neetu can take the second session.
Yes, ma'am. Thank you so much, ma'am. Can we have the CV deck, please? After the wonderful session by Dr. Kalyani madam, we will move for the second scientific session. The second session is of Dr. Ritu Hinduja madam. She will be talking on freeze all strategy, revolutionizing the success rates in IVF. To chair this session, we have Dr. Anu Agarwal ma'am. She is currently National Executive Member of ISAR, and Dr. Pragya Suryavanshi madam. She is Secretary of Chhattisgarh Chapter of ISAR. Dr. Anu Agrawal ma'am is Director of Vansh Fertility and Test Tube Baby Center as well as Ayushman Hospital, Multi-Speciality Hospital Private Limited. She is also the Executive Committee member of National ISAR and Joint Secretary of VOGS. She is a keen academician and special area of interest in minimally invasive fertility enhancing surgeries and ART. We welcome you, ma'am, to chair this session. Our second chairperson for this session is Dr. Pragya Suryavanshi madam. She is currently senior consultant and IVF specialist at SMC Hospital and IVF Research Center. She is a national faculty and also ex-consultant at GRMC Gwalior, Pandit JNM Medical College Raipur and GMC Nagpur. She has received many awards for her presentations, and she is currently the Secretary of ISAR Chhattisgarh Chapter. She held the past Joint Secretary of ISAR Chhattisgarh Chapter. We welcome you, ma'am, to chair this session, and surely we will be benefited by presence of both of you. And now I hand over the session to our chairperson to introduce our speaker and carry forward the session.
Yeah. Good evening, everybody. Thank you, Dr. Monica, for inviting me in your Synergy series. That you're doing wonderful, wonderful programs. Now to introduce Dr. Ritu Hinduja. She is a clinical director at Nova IVF, member of Managing Committee ISAR, member of Managing Committee Maharashtra Chapter ISAR, and she is editorial board of Indian Excerpted Edition, Green Journal of Obstetrics, ACOG official journal, editorial board of Indian Excerpted Edition, ESHRE, Human Reproduction Journal. And she has been awardee of MOX Shantabai Gulabchand Traveling Fellowship Award 2014 to 2015, MOX CG Saraiya Traveling Fellowship Award, MOX Banban Navnati Traveling Fellowship Award. So many awards to you, Dr. Ritu. So it's really great to have you here. And she's a recipient of the Best Paper Award at MOX Annual Conference. MOX Youth Council Lead. She's MMC accredited speaker. She has authored many chapters and also has to her credit many publications in index journals. And she's the editor of Nova Handbook of Infertility, Abnormalities of the Pelvis, and the editor of Nova Textbook of Infertility. Welcome, Dr. Ritu.
Welcome, madam. And we are really honored to hear you. And today's topic is freeze all strategy. And over to you, madam.
Thank you, Dr. Anu, and thank you, Dr. Pragya. How good am I a speaker? We'll only come to know after my talk because
We know.
Kalyani has given a very structured talk today, and I'm here to destructure everything. And I know that I've been called to answer a lot of questions, but I think I'm going to be leaving you all with a lot of questions to be answered for yourself, because I think great minds only work better when they are forced to think. So thank you, Monica ma'am, for inviting me for this wonderful series. I have only been like an observer of this series, and today it's an honor to be a part of this series as well. It's double the pleasure doing it with someone from Bhopal, because mera na Nihal Bhopal se hai, and to be doing it with my very good friend Kalyani, because Monica ma'am insisted that I do it with Kalyani. And my embryologist, Dr. Rahul, I'm sure you all are going to get very good inputs from him as well. So moving on with my talk, Freeze All Strategies, Revolutionizing the Success Rates in IVF. So now we know that IVF has been around for a very long time now, and we've also heard about the success story of the first test tube baby giving a birth to a very normal, healthy baby herself. And Kalyani spoke about the first baby which was born from cryopreserved embryos, etc. So yes, we've come a long way. We have actually seen it all in IVF, and we have been through what works, doesn't work, going back to that worked better kind of a scenario in IVF. We keep doing a lot of to and fro in IVF. So from there, I am going to take the talk of vitrification. So we all know the number, the amplitude of IVF cycles that are going on in the world. In 2018, they were reported to be around 2.4 million ART cycles that were estimated. But I'm sure this was just the tip of the iceberg. There were many more which were happening but not reported, and this is just from their database. So there were third world countries, there were countries which are not contributing to their database. Those IVF cycles were also happening. We have live birth rate amounting from ART, which is tremendous. But today, if you go to see the analysis of world data tells us that the success rate of IVF is still very guarded. We still are not talking about, I know a lot of IVF clinics claim that they have an 80-85% success rate, 90% success rate, but that's not the truth. We all know is that as practicing IVF consultants, that we still have a very guarded success rate in IVF, in spite of the years that this technology has withstood the test of time. It's still here, it's still helping couples, but we are still stuck at a particular number of success rate that we've not been able to increase. Yes, there are a lot of strategies that we have come across, and there are a lot of strategies we do apply in our practices to kind of increase the success rate. One of them, and my favorite, being the frozen embryo transfer or cryopreservation of embryos. What could be the reason of this guarded success rate? There are two reasons. It is the egg in the soil, the seed in the soil theory again. It can be the oocyte or the embryo, the quality of it or the genetics of it, or the endometrium, right? So I'm going to come and talk to you about going back to the basics, because without basics, there is no advance, okay? So we have to go back to the basics. And when we go back to the basics, we come to know that in a normal ovulation cycle, there is a rise in estrogen and there is a rise in LH. But we come to know that as soon as this rise takes place and ovulation happens, these two hormones decline, and then there's a rise in progesterone, right? So it is so simple to talk about it, but when it happens inside a female body, it is not that simple. Females are not simple. We were never born to be simple, right? We were from Venus, so we are never meant to be simple. It's not that simple. It is a very complex interplay of hormones that takes place, which makes sure that there's ovulation, and then in the luteal phase, there is endometrium receptivity. Now coming to that, so if you've understood that after ovulation is when the progesterone exposure to the endometrium takes place. So you have to understand that when we are doing a frozen embryo transfer, the embryo plus, so whatever stage of embryo you have, suppose if you have a day 5 embryo, you have to add 1 more day of progesterone to your hormone replacement cycle to be able to get the right endometrial phase where you'll be transferring the embryo. I'm sure all of us do it. So it's day 0 of ovulation and then 1, 2, 3, 4, 5. And that's when you do the embryo transfer, right? So now coming to endometrium receptivity, where progesterone is the, I won't call it the hero hormone, the heroine hormone. The heroine hormone is progesterone, because of the exposure of which the endometrium becomes receptive, right? Now, it is again, you have to understand that we talk about window of implantation. Not every phase after the exposure of progesterone is the endometrium receptive, right? There are apoptotic changes also that start taking place after a certain amount of exposure of progesterone. Now we talk about window of implantation, and I know that you all will say yes. So what is window of implantation? And I know that all of you all will say window of implantation was defined long time back in 1973, where they said that window of implantation is LH plus 7 to LH plus 10. Yes, I know that it is LH plus 7 to LH plus 10. But at that time, IVF was not there. ART was not there. How did we define this window of implantation? This window of implantation was defined by histopathology. By histopathology, they defined the window of implantation. Now, I will talk about that as well. So in 1973, Noyce criteria said whatever histopathological changes that we are seeing is equal to dating of endometrium, where there was gland mitosis, there was pseudo-stratification of nuclei, basal vacuolation, secretions, stromal edema, stromal mitosis, whatever you may say. And an out of phase endometrium was any phase that showed more than 2 days of delay. Again, emphasizing that window of implantation was dated or was defined by histopathological findings and not ultrasound findings or measurement of hormones that we practice today. So window of implantation was defined by histopathology. If you have a good histopathologist, the histopathologist can tell you the exact day of the endometrium that the biopsy has been taken from. Why? Because on a daily basis, there are changes in the endometrium that takes place. It doesn't mean that when I'm saying LH rise plus 7 or LH rise plus 10, the endometrium becomes static, that the click is taken. No, it is a movie. There are changes taking place in the endometrium on a daily basis. Very dynamic. The endometrium is very dynamic. And so to say, you may feel that the window of implantation is very, very wide, but I am sorry to say that window of implantation is not as wide as you or I may think it to be. Window of implantation is very small. So, and I'll come to it. You will say that, but there is endometrium receptivity array, which tells us the window of implantation for a particular patient. Yes, but have you read the reports? And anyone who's done gene expression on endometrium will agree to me that when we get the endometrium reports or the ERA reports, they tell us difference of hours. It can be 1 hour, it can be half an hour. So you understand that the window of implantation shifts in an hour's time or in half an hour's time. Then how can we be so sure that window of implantation is a very wide place where we can play? The playground is not that wide. It is a very narrow playground that we play in when we talk about window of implantation. Receptive versus non-receptive is a very small journey that the endometrium takes. And when does it take? It's very difficult as a doctor to kind of pinpoint that where are we landing when we are trying to make the implantation. So even when you see these reports that come, they always tell you where the endometrial biopsy must be taken on day P plus 5. So the day the progesterone has started plus another 5 days. So 0 plus 5. And if you are doing it in a natural cycle, if you're doing it in a hormone replacement cycle, all these things have to be given to the laboratory who is doing your gene expression on the endometrium. And why is that? Because window of implantation does not stay same when you're giving an HRT, when you're doing a fresh natural cycle FET, or you're doing an FET in a modified natural cycle. A lot of people feel that when they're doing a natural cycle FET, giving HCG, making sure that the follicle has ruptured, that is not natural cycle FET. That is a modified natural cycle FET, and the exposure of the endometrium to HCG increases the amount of progesterone that the endometrium is getting exposed to. It is not the same endometrium as the endometrium of a natural cycle FET. So this is where we are trying to land. We're trying to land on a very short runway. And this runway becomes shorter when we stimulate the patient. We all know that when we use ovarian stimulation, there are changes in the endometrium that takes place, which are pro-inflammatory. They have cytokines which are released. They have anti-inflammatory cytokines. They have a multiple variable of, vascular endothelial growth factors, interleukins, etc. A lot of cytokines are being released by the endometrium, which is stimulated while we are stimulating the ovary. And this is not really very good. It is not very good for the implantation. So you have to understand that two different endometriums that we are talking about when we are doing a fresh transfer or a frozen transfer. As clinicians, we really like to simplify things because it simplifies things for us in our practice and it simplifies things for the patient. So when we say, oh, very good, your endometrium looks trilaminar, the thickness is very good, it looks very good, let's start and plan your embryo transfer. These are ultrasound findings. No doctor in today's day and age can tell me whether the endometrium is receptive or not receptive by just looking at the thickness or the morphology of the endometrium. It is an ultrasound finding. It is an indirect test. It is an indirect test to let me know that it looks good. Maybe I can introduce progesterone at this time and then do the implantation, right? So even if your endometrium looks good in a stimulated cycle, it is not necessary that the endometrium is receptive. And that is why frozen embryo transfer cycles are much more in control because we control the exposure of progesterone. The interplay of hormones that I had showed initially it's basically nullified. We are not letting any activity take place. We make sure that the estrogen is given. We make sure when the progesterone enters, we make sure that the endometrium is prepared according to us. The timing is in our control. So we all know Kalyani has spoken about the human embryo freezing and how we used to do it in the past. Hormonal preparation was used first. In that, GnRH agonist down regulation was used. Now we don't do that much of down regulation, and I'll come to those slides later on as well. There are different hormonal preparations that different consultants or IVF specialists use, and none is superior or inferior to the other, whatever suits your practice. I'll also come to, whether you should give progesterone, not give progesterone, etc. But cryopreservation had made such an impact on our clinical practice that fertility sterility at some point had started talking about, should we eliminate fresh transfers from our practice completely? And should we move to an all-freeze cycle? There was an era where we were talking about all-freeze being better than fresh embryo transfer. And then came another phase where we said, no, but fresh embryo transfer and frozen embryo transfers have the equal success rate. And then again, we are shifting towards frozen embryo transfers for various reasons. So and I'll come to those reasons in my future slides. So whether you should be doing fresh or whether you should be doing frozen is a question that still needs to be answered. And Kalyani has shown some very beautiful papers from high impact journals. But again, just because they are high impact doesn't mean those papers were done correctly, right? So you have to understand that in an IVF worldwide survey, when they studied FET, they studied the thickness of the endometrium, and they came to a conclusion that 7 millimeters of endometrial thickness is somewhat where we would like to transfer the embryo, and not more than 12 or 11 millimeters of endometrium. Now, the preferred preparation of FET in ovulatory patients that they studied was natural cycle, HRT, ovulation induction. Okay, so natural cycle and HRT were most common, and very few people did in ovulation induction, the frozen embryo transfer cycle, and preparing the endometrium. Again, I will come to why these kind of what protocol to use in which patients. Now, there was a study where they were comparing estrogen and progesterone FET versus natural cycle FET, and their end result was clinical pregnancy rate per woman. Now, this was a Cochrane database, okay, and it was a meta-analysis. Now, a meta-analysis by definition is when you they include RCTs and randomized controlled trials, and you study their data and they study their findings and you publish it. But this Cochrane database was never published. Why? Because they had all studies which were included. They were all retrospective studies and none of them were randomized controlled trials. And that's why this was just a presentation in one of the meetings and it was never published per se. So again, there was another Cochrane review which was then published, and it said that they found moderate quality evidence showing that one strategy is not superior over the other in terms of cumulative live birth rate, and time to pregnancy was not reported, but it can be assumed to be shorter using conventional IVF strategies in case of similar cumulative live birth rates as embryo transfer is delayed in freeze-all strategies. This is the only conclusion they had given, but they had failed to take into consideration in an FET cycle, how was the endometrium prepared? Was it a natural cycle FET? Was it a hormone replacement cycle FET? Was it a modified natural cycle FET? How many days of progesterone was the endometrium exposed to if HRT was given? In a natural cycle FET, was progesterone given after the embryo was transferred, not given after the embryo was transferred? A lot of factors and a lot of questions were not answered. So to say that both the strategies are equal was a little bit of an understatement, because some of the studies were not done with the same variable into perspective. So I feel that we should try to do a randomized control trial where all these factors are taken into consideration. Only one protocol is used and only one, the similar days of progesterone exposure is given to the endometrium. Right now, coming to the progesterone that was given to a lot of women, and I've studied a lot of papers to make this talk, that a lot of people gave injectable progesterone because they felt that that was superior to the other formulation of progesterone for endometrium receptivity. Specifically, people from the United States of America believe that injectable progesterone is much safer and better in terms of serum progesterone levels and endometrium receptivity when coming to doing a frozen embryo transfer or, embryo transfer. And they do not believe in a lot of vaginal progesterone as well as oral progesterone. Again, oral progesterone having its own baggage that it carries because of various studies that were published in the past, but also talking about immunomodulation that comes with the dydrogesterone group of drug that is being kind of promoted. So there were a lot of papers with conflicting views about the progesterone that you can use in a frozen embryo transfer cycle. This again was from the New England Journal of Medicine, again a very high impact journal of medicine, where they spoke about transfer of fresh versus frozen embryo transfers in ovulatory women. And it said it doesn't differ between fresh embryo transfer and frozen embryo transfer among ovulatory women with infertility, but frozen embryo transfer resulted in a lower risk of ovarian hyperstimulation syndrome. Again, in this journal, they did not talk about in what kind of cycle was the frozen embryo transfer done. They just spoke about frozen embryo transfer and fresh embryo transfer, but how do you prepare the endometrium is also very, very, very important. This was a very interesting study where they did a gene expression profile of human endometrium receptivity, comparison between natural and stimulated cycles for the same patients, where in the materials and methods it was written that the LH surge was felt by the patient herself, which was, I felt, very, very erratic because the patient cannot feel the LH surge. And even the LH strips that are given to us given to the patient are sometimes not very accurate while measuring the LH surge, because the LH surge could have happened at any time and the woman may be testing it later. And if, it could come negative even after the LH surge has happened. So, LH surge being estimated by the patient herself was, I think, a very, it was a loose end that needed to be tied. It didn't really make sense in this study. Again, now this paper was found where they spoke about cryopreserved cord embryo transfer in spontaneous natural cycle and compared to modified natural cycle, which I've been talking about. Now, this cycle actually compared two kind of natural cycles that we talk about, right? Spontaneous natural cycle where they did not do any kind of intervention versus natural cycle in which they give an HCG trigger to make sure that the ovulation happens and they could time the frozen embryo transfer. And then the conclusion resulted that there was a superiority of the natural cycle as compared with natural cycle controlled by HCG. So modified natural cycle was a little inferior to the natural cycle without any kind of intervention when it came to cryothawed embryo transfer cycles. So this paper had a clear-cut answer for us, saying that when you come to prepare the endometrium without HRT, if natural cycle is being done, whether you give HCG or don't give HCG, when you don't give HCG, there is a higher success rate than when you give HCG. Again, there were a lot of papers which said that there's an increased preeclampsia risk and reduced aortic compliance in vitro cycles, in FET cycles. But you have to understand, in FET cycles, in HRT cycles, where there's an absence of corpus luteum, of course. Why? Because absence of corpus luteum leads to preeclampsia. So if you're doing a natural cycle or a modified natural cycle, that will take care of the absence of corpus luteum and will decrease the risk of preeclampsia. Thereby, FET kind of frozen embryo transfer kind of absorbed itself from the tag of having a higher rate of preeclampsia. Now comes the question, a lot of people would like to substitute the cycle with GnRH agonist or without GnRH agonist. Of course, I understand that a lot of people would like to down-regulate with agonist to avoid spontaneous runaway ovulation in an E2 progesterone substituted cycle. But is it really necessary? Because if you've given like a high dose of estrogen, I have never seen an ovulation or a runaway ovulation happen. So according to me and according to the studies that I have read, there is no difference, no statistically significant difference in the outcome of frozen thawed embryo transfer cycle in cycles which are treated with decapeptyl, that is agonist, or without agonist, and the success rate was equal. So, and if you're giving HRT, then a high dose of estrogen should take care of the runaway ovulation that you're talking about. So it's really not needed, but if you think that it gives you peace of mind, you can go ahead and use an agonist in your cycle. Now coming to why are we endorsing vitrification? Because technologies have changed. We have come from a long way from then to now. Like everything evolves, our technology has also evolved. Vitrification has evolved from slow freezing to vitrification, and vitrification in itself as a process has also evolved. The finesse of our embryologists to do the procedure has evolved. Our protocols have evolved. Our endometrial preparation techniques have evolved. We are now moving towards natural cycle frozen embryo transfer cycles. So a lot has evolved. We have learned from our past and we are building a better future for ourselves and our patients. So of course, a lot of people are moving towards frozen embryo transfer cycles. So if today, standing today, if I look back 13 years that I've been practicing, I cannot even recognize the practice that I used to do that back then. It is very different. It is evolving. And every time that we are talking about advancements, I think vitrification, freeze all is one of the best advancements that has taken place, along with, of course, pre-implantation genetic testing, etc. But I think vitrification, freeze all techniques have come a long way. It's not only helping us as the clinicians increase the success rate, but also helping women, like we were talking about, with poor ovarian reserve, cryopool their embryos to be able to have their own genetic child. 13 years back, if you asked me to do a self cycle of a woman with 0.8 AMH, I would not even have thought of it. I would directly tell her to go ahead with donor egg IVF. But today we are proudly, all of us are able to handle cases with low ovarian reserve and low AMH only because we know that we stand with a strong backing of something like vitrification and a very strong embryology team, which is so well trained in our vitrification program. So in the conclusion, I like to say there are very few and insufficient RCTs assessing the different methods of endometrial preparation prior to FET. The present data supports the complete and detailed natural cycle in normal cyclical patients. In irregular cycling patients, substituted cycles with or without GnRH agonist can be used. So if you have a woman who is ovulating, who has a good 27 to 30 days cycle, it is recommended that you do a natural cycle FET. And if you have a woman who's anovulatory, you have no other choice but to do an HRT FET. However, there's an urgent need to do a randomized control trial comparing all these parameters, making sure there is uniformity, making sure that equal number of progesterone days of exposure is there, making sure that the FET is done in a particular manner and not just comparing frozen and fresh embryo transfer cycles. And at the conclusion, I'd like to say technology is not just a tool. It can give learners, we as learners, a voice that they may not have had before. So thank you very much for your patient hearing. And I hope that y'all are going back with a lot of questions to ask yourself as to what we should do when we are doing a frozen embryo transfer cycle. Thank you very much.
It's what to say. It's just a mesmerizing, mind-blowing talk. What all it was really, I was expecting this only. And we are really very much, it's very practical also what you talked about. But one thing I want to say that you said the heroine is progesterone. What is your say about the estrogen?
I think estrogen, the body is like I said, natural cycle is always there. So, the body is already making the estrogen. Whatever receptivity, the secretory changes in the endometrium only takes place because of the exposure to progesterone. The endometrium only becomes receptive because of the progesterone, not because of estrogen. So if you see in an anovulatory cycle in a woman with PCOS, there is unopposed estrogen. There's always estrogen. हमें estrogen की कमी नहीं है. The progesterone doesn't come in these women, and that's why the endometrium never becomes receptive. So the god hormone is progesterone when it comes to endometrium receptivity.
Ritu, I want to ask a question that nowadays I'm also using some patients, I'm putting them on letrozole.
Yes, ma'am.
In order to predict the ovulation, because letrozole is a molecule which is just like you can predict how it
Yes,
acts, everything. But there were a couple of patients who were mild to moderate PCO, where after HCG, naturally I gave letrozole, I gave 5K HCG, urinary HCG, ovulation did not happen. So the follicles remain the same size. Now, how do you plan your frozen embryo transfer?
Ma'am, you cannot plan your frozen. If ovulation is not taking place, how will we plan our because the progesterone, it will only come after ovulation. If you go back to the basics, the ovulation will happen and progesterone will only come when there's ovulation. So if just in case, if by 5,000 HCG, ovulation is not happening, maybe we can try increasing the dose to 10,000 HCG or using a recombinant ovitriol kind of molecule where ovulation we can try it. I don't know what will happen because I've never used letrozole for inducing ovulation, but it should not be a factor why ovulation is not happening. Maybe we can try with a 10,000 HCG or 250 of recombinant HCG.
This issue was also discussed in ISAR Aspire in Pune, I think a couple of months back. Anu was there.
I was there.
Yeah, so there was a panel which was being moderated by Dr. Sunita Tandulwadkar and Dr. Pai. And they were questioning all international speakers. And I distinctly remember they said that it doesn't matter whether ovulation happens or not. You just proceed with your FET. Remember, Anu? And we were
No,
Yes.
so ma'am, if you are proceeding with the FET, that means you are not doing you're doing a modified natural cycle where you will substitute progesterone from outside. If
Yes,
you are
that's-
if you're substituting progesterone, then how does it matter? Because you're exposing the endometrium to the progesterone.
but the corpus
I am
luteum,
talking.
but the corpus
But
doesn't-
ma'am, see, when an HRT cycle, in an HRT cycle, there's no corpus luteum, but we are exposing the endometrium from exogenous progesterone, and in that also we are getting success rate. I am talking about something where you're not giving exogenous progesterone. So if you're not giving exogenous progesterone and you're completely relying on the corpus luteum to take over the role of exposing your endometrium to progesterone, then you cannot do the FET without ovulation. But if you are giving exogenous progesterone, suppose if you're considering you've given an HCG trigger, then 36 hours later you did a pickup and then you start your progesterone. If you're doing a cycle like that, then how does it matter whether there is an ovulation or no ovulation? Because any which ways you're exposing the endometrium to progesterone exogenously. I'm talking about endogenous exposure to progesterone. So if there is no ovulation, but you're exogenously exposing the endometrium to progesterone, we can proceed however it is.
So you mean to say, Ritu, like then cases with documented ovulation, you completely trust on the progesterone secreted by the corpus luteum to carry your embryos to viability? You do not
Correct.
supplement with exogenous progesterone?
Ma'am, if you're asking me, I don't dare to do that. But if you go to see Fatemi's paper, they are completely relying on the endogenous progesterone. They are not giving any exogenous progesterone in their terms natural cycle FET. If you have given anything exogenously like an HCG or progesterone, then they are calling it a supported natural cycle FET, which makes sense actually, because then there is nothing natural about it.
Yeah. And Ritu, tell me about the counting of the days. There's a lot of confusion. Some people say 100 hours. The range is about maybe 100 to 120 hours of, post-fertilization. Like, how do you count from the LH search, your day of transfer? Or how do you count from the ovulation or the fertilization? Which is the best way of counting?
Okay, so when I do the pickup or when there's
I
ovulation,
think Rahul will also talk about it, but I wanted you to explain, ma'am, just.
Ma'am, Rahul will tell you my protocol only.
Yeah. But I thought maybe Rahul is thinking I'm asking you questions. I should have been asking him. But still, I need you to explain. Yeah, Ritu.
So, ma'am, when I do the pickup or when there's ovulation, that is day 0. And then I generally do day 5 transfers. And in my practice, even if it is a day 6 embryo, the stage is day 5 only. That even if it is a slow growing embryo, which has gone up to days that I had to observe up to day 6, but the stage is day 5 only. It is the blastocyst embryo only. So day 0 is when ovulation takes place or when pickup takes place. And from there, I start counting day 1, day 2, day 3, day 4, day 5. So in total, there are 6 days of progesterone exposure before I transfer the embryo. But the easy way to count it is count your pickup day as day 0 and then they go to day 1, day 2, day 3. So if it's a day 3 embryo, it will transfer on day 3. If it is a day 5 embryo, day 0, day 1, day 2, day 3, day 4, day 5. Simple. So start counting from 0 and count up to the day of the embryo stage.
There are some people, some embryologists who say, or clinicians who say that the endometrium has to be a little advanced as compared to the embryo. Is it like sometimes it works? Maybe that is why we call
So,
the
ma'am, I have come across a lot of people and they say instead of doing ERA cycle, why don't you just give one more extra day of progesterone and see the implantation will take place? The beauty of medical science or the beauty of specifically ART practice is that women are very complex and so is their system. I think nobody is wrong. There is a school of thought out there, but I have never dared to give day 6, one more day of progesterone in my practice per se, because it is non-physiological if you go to see physiology. That is why I explained the basics in the beginning. And that is why I emphasized on the day of progesterone exposure, because if I go back to my Gardner, if I go back to histopathology, it is always the day of ovulation plus another 5 days if it's a blastocyst, or another 3 days if it's a day 3 embryo. for me to be I have done one more day of progesterone exposure if on ERA it has come as a suggestion that do the embryo transfer one day later. But without a documented ERA and just going ahead and giving one day extra of progesterone exposure, I have not dared to do it.
Okay, thank you, Ritu.
Thank
That
you.
was a beautiful, beautiful talk, and
Thank you.
you did complete justice to it.
Thank you,
And
ma'am. Thank you so
thank
much.
you so much for
Wonderful
joining.
lecture.
Wonderful,
Thank you,
wonderful.
Doc. Thank you, Dr. Thank you
So,
so much.
so Dr. Monica, Dr. Ritu, I just had one thing that I wanted to add it here in the discussion of the levels of the progesterone and the days of exposure. So, in between, if Ritu, if you remember, there have been times that, you know, when we have
Kalyani, your voice is gone.
I think she's traveling now.
Yeah.
अच्छे से develop नहीं हुआ है और there has not been any growth. So I had done few readings and research that, you know, how can I give a better outcome growing?
Kalyani, we can't hear you.
I think we'll ask her to put that in the group, whatever input she has.
You freeze this embryo, but when you do the frozen transfer, so technically what we are going to do, because we are frozen on day 6, we are going to make the exposure for 5 days and do the transfer on day 5 of the progesterone. That's 0 plus 5, what Ritu said. So is even if it's on day 5, day 6, or day 7, if it's an, you know, it's an compaction, do the exposure of the endometrium only for that 4 days of what the stage of that embryo is, and then do the transfer. So your understanding is basically the synchronization of the endometrium and of the embryo which is taking place. So that is just, I wanted to make a note of it.
Ritu, are you here?
Yeah, I'm absolutely
Yeah,
here.
Ritu, I wanted. Yes.
Yes, please tell me, Dr. Anand. I'm here.
I wanted to ask you, you are doing natural cycle or modified natural cycle?
I am doing the modified natural cycle because
This is what I want to ask.
No, I am doing absolutely modified natural cycle because Rahul is here and he'll kill me if embryo transfer starts coming on Sunday. He'll tell me, Madam, meri bhi family hai. So, no, I'm doing modified natural cycle because I like to be a little bit in control. If I don't like to lose control over my cycles because then they become very erratic. And then what if the ovulation takes place at night and I am not aware about it when the patient comes, I get very scared. But this is the research that I have done. And I have heard a lot of talks. And so I just wanted to put it out there that this is something that people can do if they have the support system to do a natural cycle, to be very, very honest, because you need a lot. Maybe you're not available, maybe you are not available to do a scan, because to do a natural cycle you'll have to do daily scans waiting for the ovulation to take place. So if you so if you have the support system, if you have a support staff, if you have Rahul, are you listening? Complying embryologist, then maybe you can do it. But no, I'm not doing it. I am doing modified natural.
So you give trigger in the natural cycle, you give trigger to plan
Yes.
the...
Yes.
Yeah.
So, Dr. Pragya, I give trigger when I feel the follicle size is around 18 millimeters. I give a trigger and then I assume that I did a pickup after 36 hours. And then I start my progesterone exposure.
So do you feel any use of letrozole adding in the FET cycle?
So if suppose I have tried to do a natural cycle FET and I've not got a recruitment of dominant follicle, then in the next cycle, I can consider using some kind of ovulogen, maybe letrozole, or maybe a very small dose of gonadotropin. That can be considered. I will never use a clomiphene citrate because it has anti-estrogenic effect on the endometrium. So it's out of the question. So yes, letrozole or a very, what should I say, homeopathic dose of gonadotropin can be used to get your
Mimic.
dominant follicle.
To
Yes.
mimic. Yeah.
Yes.
Letrozole gives you a good endometrium as well. Whatever cycles
Yes.
letrozole, it gives you a very fantastic that
Endometrium.
fine appearance.
So I really love letrozole in that part.
Even I am using letrozole in these cycles. It
Modified
gives wonderful results. The
in your
cycle
modified
control.
cycle,
So
Ritu,
it gives
when
little.
when you give the HCG, do you monitor, document the ovulation?
Yes, ma'am. I do.
Okay. So that is once you document, you start counting the days.
Yes, ma'am. Yes, ma'am.
Right, right.
But if
So
even
when
if
you
it
give
doesn't ovulate,
HCG,
we can start LPS.
Yes, we can definitely. But वो ovulation देख के एक
So you
satisfaction
start-
मिल जाता है. So I do a ultrasound.
हाँ, बस वो अपने satisfaction के
Like
लिए
you have done-
absolutely start.
so you after HCG trigger, after 36 hours, you see the ovulation, or by the next day you start, or 36 hours?
No. After 36 hours, I make sure I do an ultrasound and confirm ovulation and then start progesterone.
Then start 0, 1, 2. Okay, so just mimic the OPU.
Okay, I
Yes,
think
yes.
I start the third talk. We are just past 7:30 now, and Dr. Rahul
Yeah.
is for his. I think we can
We
connect.
really enjoyed.
Yeah. So the third talk, please. Dr. Nandini is there, or Purva, you are doing it?
Good evening, ma'am. I'm there, ma'am.
Yeah, Nandini.
Good evening to one and all. Our third talk is purely on an embryology by a very eminent speaker, Dr. Rahul Salve, sir, and he will be speaking on vitrification and IVF, the science behind freeze-all. Our session will be chaired by Dr. Monica Singh, ma'am. Can we have a CV, please? Dr. Monica, ma'am, CV. Madam is National Executive Member of ISAR. Madam is the Founder President of ISOPAP Chapter of Bhopal. Madam is the Vice President of Bhopal Obskyne Society, and she's also the Vice President of Bhopal Menopausal Society.
It's
She's
okay,
a
Nandini. It's okay, Nandini. I think I'll just share the session because Randhir is not available. So I'm, filling his spot. And I think I'm the only chairperson.
Yes, ma'am. Yes, ma'am. I request Madam to kindly introduce the speaker for today. Thank you, ma'am.
Of course. So it's a great honor and pleasure for me to introduce Dr. Rahul Salve. And thank you, Ritu, for introducing me to Dr. Rahul. He is the cluster head embryology of West Nova IVF Fertility, associated with Nova since 2016, completed PGD Clinical Embryology and ART from Bangalore University in 2014, MD in Biochemistry from VMGMC Sholapur 2013, MBBS from RGMC Kalwa Thane 2002, more than 10,000 ICSI procedures he's done, PGTA, aneuploidy, and more than 400, vitrifications more than 10,000. And he has also recently authored a chapter in a book called ABCD in ART and Sperm Selection Strategies. That's a wonderful CV, Dr. Rahul, and we can't wait to hear from you.
Okay. Yeah, hi. Is my screen audible, visible? Sorry.
Yes, it is.
Okay. So, good evening, everyone. After I can see everyone smitten by the earlier two presentations. So, I may not reach that level, but I would just like to leave with a good impression. We'll start by introducing the topic. The topic is vitrification IVF, the science behind it.
Can you put it full screen, please, Dr.
Yeah,
Rahul?
this
Yeah.
one. Is it visible now?
No, it's not full screen. It's still in the normal mode, normal view.
This one. Can someone from the support do this? Because I am finding it difficult to do it.
Dr. Rahul sir, below in
Yeah.
the PowerPoint presentation, below there is one marker below the percentage near the right corner. Yes, come down, still come down, still come down. Go to right side. Come down, come down, come down. Your marker. Go right side. Little bit left.
There's a slide. No.
That is go to right side. Go to right.
Oh, the screen has gone now.
Just a minute. I will start again, and you
Yeah,
just
try
guide
checking
me.
again. Yeah.
Now still it's normal mode.
Yeah, it's
normal
normal.
mode.
Okay.
Now click.
Is
There
this
is complete.
Rahul,
yeah.
on the red bar, there is animation, and on side of animation, there's slideshow. Click the slideshow.
Yeah, I would click the slideshow now. Is it visible?
No, it's not.
Go to the top. Go to the top.
वो red bar में ऊपर there is slideshow next to animation.
No, not here.
Okay. Okay.
Yeah.
है ना? And then from beginning, go the first one. Yeah.
Is it okay now?
Actually, it's not happening this way also. So I think you can proceed. We can see your slides.
It is visible.
It's okay. It's okay, Rahul. You can proceed.
It's okay.
Yeah.
Okay. So we'll start with the science behind the vitrification. Initially, we'll start with something simple. Why vitrification has gained so much importance today? Because it is a promising technique and it has the potential to influence the ART. It has high acceptance from embryologists, and there is ever increasing demand for storing surplus embryos and fertility preservation. And the most important thing is vitrification does not have any of the biologically damaging effects associated with freezing because no appreciable degradation occurs over time. Is the second slide visible clearly?
Yes,
Hello?
yes.
Yeah, okay.
Yeah, no
So the
problem.
the credit to the concept of vitrification goes to Louet in 1930s. He observed that the hazards of crystal formation are significantly reduced by rapidly cooling the biomaterial to low temperatures. And he defined that vitrification is the kinetic process by which a liquid solidifies into a glass. And this glass is actually a liquid that is too cold or viscous to flow. In 1930, Walter Stiles also observed that the reason for the death of plants at below freezing temperature is because there is disturbance in the relation between the dispersed phase and dispersion media in the protoplasm. Protoplasm is cytoplasm plus nucleus. So in a plant cell, there is a disturbance in the relationship between the cytosol and the organelles. He too proposed that by very rapid freezing, it is possible to form a finely crystalline or even amorphous mass that might give the original system again on thawing. This is a typical cell which is the reason for showing this slide is it.
So slides are not moving, Rahul. Are they moving?
Yeah, not moving.
Can you? Yeah, now we can see the cell slide. Yes.
Okay. So the cell is actually is also colloidal in nature. It consists of 80% water and inorganic and organic compounds, and the cytosol, that is a gelatinous liquid that fills in the space between the cell organelles and the cell membrane. So in 1937, Louet in his experiment on vitrification of organic colloids, and of protoplasm, he observed that the most important problem of vitrification technique consists of obtaining a cooling velocity sufficient to prevent the formation of ice crystals. So Lewitt also stressed on that the speed of vitrification, speed of cooling or the cooling velocity is more important to achieve vitrification. Now this is the most important slide, that is which is the mechanism of vitrification. Vitrification refers to a process wherein solidification of a liquid occurs to form a glass-like state, not by ice formation but by extreme elevation in viscosity during the process of cooling. Now this extreme elevation in the viscosity during cooling is achieved by cryoprotectants. So viscosity is due to the presence of cryoprotectants. This is the reason for mentioning this first point. Now, while being cooled to extremely low temperature, this liquid will meet its glass transition temperature, at which the change from liquid to solid phase occurs. So just to make a note from this point is that there is certain thing called as glass transition temperature at which glass formation occurs. Then when in a glass state, the solution is technically liquid but is too cool to flow. And the most important thing why vitrification has gained importance is because throughout cooling at lower and lower temperatures, the molecules will remain in the same disorganized way as they are when in a liquid state. Means the stage of the embryo or oocyte frozen will continue for several years during when the embryos are stored after vitrification, and it will be the same on thawing. And the physical properties of the liquid are now comparable to those of a solid. Therefore, molecules are held in the same pattern throughout the whole process. Now, this is a hypothetical phase diagram of aqueous solution of cryoprotectants. Now, can you see my cursor moving on this graph? Is my cursor visible on the graph?
This I cannot see the slide moving. We are on mechanism of vitrification.
Okay, I think there is some delay.
Yeah. What about Dr. Pragya? Dr. Vishal, can you see the slide moving?
Rahul, can you email or WhatsApp the slides to someone and they can show the slides for you? Yeah, okay, we can see the graph now.
Yeah, the graph is visible now.
Achha, now it's visible. So earlier slides were visible?
Yes.
Okay, so this is visible now. Okay, fine. So this is a hypothetical phase diagram. Can you see my cursor moving on this?
Yes, it's visible.
Okay, okay, fine. So I will just explain very briefly. The x-axis is the cryoprotectant concentration and the y-axis is the temperature. Now this TG, this curve, this is our focus like TG. Now this is an aqueous solution of cryoprotectant. So this the entire temperature curve is for the cryoprotectants plus cell contents like the cytoplasm. This cryoprotectants is already in the cell. So this phase diagram will study the effect of temperature on the aqueous solution of cryoprotectants or cryoprotectants inside the cell. Now our focus is reaching this temperature TG. TG is glass transition temperature. Now this TT is equilibrium freezing temperature. So above it, everything will be at liquid stage. This is the freezing temperature. Below this TT and TH, this will where freezing will start or the ice crystals will be formed, and TH is the homogeneous nucleation temperature. So below this temperature, what happens is the crystals which are formed in this stage, they will nucleate or they will coalesce or they will fuse together to form a hexagonal structure that is nothing but ice. So this is the frozen stage. So the trick here is when suppose we are culturing embryos or oocyte which are above this temperature, above the TT, like at 37 degrees centigrade. So to reach this TG, the embryo or the oocyte will have to pass through this, which is the crystallization state, where isolated water isolated water crystallizes, ice crystals are formed, and then this stage also, which is the frozen stage where actual ice forms. So uh, on the x-axis, this is the cryoprotectant concentration. If you see, the higher the cryoprotectant concentration, the lower, or the Tg is much higher than what is at lower cryoprotectant concentration. But the trick is, as we increase the cryoprotectant concentration, because of the toxicity, it could damage the cell. So our focus should be at lower cryoprotectant concentration. So at lower CPA concentration, we will have to reach much lower degree, much lower negative temperature, so that we avoid this crystallization at this frozen stage. So we will have to be very fast, or rapid cooling, or the cooling velocity has to be very fast, so that we bypass all these stages to reach the Tg. So this is the reason why we after loading on the cryotop or on a carrier, on cryotop or cryotech or whatever device, it has freezing or dipping in the liquid nitrogen has to be very fast. Now the other important thing is, this is a TD. TD is devitrification temperature, or incomplete vitrification, or crystallization state. Now the importance of this state is, it is very close to Tg. So suppose we have frozen and kept it at the Tg, and we have stored it. But while thawing, suppose the temperature rises and it reaches till Td. So ice crystals will be formed again, and it will damage the embryo or oocyte. So while thawing also, it has to be so fast that we will have to bypass this Td, or crystallization state, or devitrification, this frozen state, and this crystallization state, and again. So this is the reason why while thawing also, we within a second we take out the cryotop and dip it at 37° TS solution. So this we have to bypass these three stages. So the main purpose of this phase diagram is to show that the speed of the cooling velocity has to be fast, because we have to bypass three stages on vitrification also and on thawing also. This is the more simplified graphical presentation. It's similar to the previous, like above this TT, it's in liquid phase. This is the ice phase. This is the crystallization or ice nucleation zone, and this is the glass transition temperature. Now, are my slides moving?
Yes, yes,
Yes. Okay. So now we'll look at that the point which I mentioned earlier, like this. Throughout cooling at lower and lower temperature, the molecules will remain in the same disorganized way as they are in a liquid state. So this is a simplified explanation. There is something called as entropy. Entropy is the measure of disorder of a system. Now consider this as a liquid. The liquid will consist, the molecules of the liquid will be at some distance to each other. If it is frozen, then it will convert it to a solid. The molecules will be a little closer to each other. In a gas state, on vaporization, the molecules will be at a far greater distance to each other when compared to liquid or solid. Now the reason for showing this picture is, the molecules will be at a distance, but molecules will be continuously moving. There will be a rotational motion, translational motion, vibrational motion. So cell is very dynamic. So molecules will be continuously moving, either rotationally or translationally, like in a pendulum, or maybe stretching. So molecules will be moving. So what happens? We'll look at the second law of thermodynamics. It's just related to entropy. That's why I included this slide. The second law of thermodynamics states that the state of entropy of the entire universe as an isolated system will always increase over time. The important point is isolated system. So the second, it also states that changes in the entropy in the universe can never be negative. Now, just will not look at the below points. So the important point over here is the second law also states that changes in the entropy in the universe can never be negative. We'll focus on these slides also. So what happens in vitrification is our aqueous solution of cryoprotectants or the embryos, the cytoplasm will be more towards this part, and we are freezing it. So suppose it will be more towards solid part. So the entropy has to be lower in a solid. So what happens exactly in vitrification is, with sufficient reduction in the temperature, the thermal energy becomes insufficient to drive the rotational and translational motions. So because of the high cooling velocity, the molecules will not be able to do the rotational or translational motion. So molecules will be at the same position where they were before vitrification. Now, what happens to the water molecules? So, water molecules will become trapped in local energy wells due to removal of internal energy, and entropy therefore stabilizes and remain above that of the ice phase. So, the point to be taken from here is, as we are freezing a liquid into a solid, so ideally the molecule should be closer and entropy should decrease. But what happens is, because of rapid freezing, the molecules don't get time to come closer or to undergo any motion, or so what happens, they will stabilize and the entropy will be that of the will remain above that of the ice phase. Means technically it will be a liquid, because molecules will be at the same distance and perform at the same distance in a liquid phase. So this event is referred to as glass transition. And the vitreous state is essentially a solid amorphous liquid state obtained by specific conditions of cooling and solute concentration that inhibit ice nucleation and growth. So at low temperatures, the viscosity of the solution becomes so high that sample gets immobilized. This sample then takes on the characteristics of a solid. So vitrification is direct conversion of liquid state into glass, bypassing or rapidly passing through the critical temperature of ice formation or no phase transition. Now, the cryoprotectants, there are two types of cryoprotectants: penetrating and non-penetrating. Penetrating cryoprotectants, what they do is, they replace some of the water and the cells contain, they replace some of the water the cells contain and increase the viscosity in the cell, prevent the formation of ice crystals, and make the vitrification process easier by inducing the transition to the glass state. Now, permeating cryoprotectants, they are small molecules and they form hydrogen bonds with water molecules and thereby prevent ice crystallization. The non-penetrating cryoprotectants prevent water from flowing out of the cell and occurrence of osmotic damage by making the membrane less permeable. These are some of the cryoprotectants: ethylene glycol, glycerol, DMSO, propylene glycol, acetamide. Non-penetrating are sucrose, trehalose, glucose, galactose. Cryoprotectants, they facilitate freezing process by lowering freezing point, protect the cell membrane from freeze-related injury, and decrease the deleterious effect of high salt concentration as cells dehydrate during freezing process. Now, the non-permeating cryoprotectants remain extracellular. They extract water from the cell and create a state of cellular dehydration. Now, to use together, the non-permeating cryoprotectants dehydrate the cell, and permeating cryoprotectants prevent the creation of ice crystals in the cell. Now, the importance of non-permeating cryoprotectants will come in the picture in the thawing cycle, where it avoids the osmotic shock. Since the reduction of osmotic pressure in the extracellular area permit exit of permeable cryoprotectants. If this does not happen, excess water would enter the cell and may cause rupture of the cell. This will be explained later more clearly. Now this picture visible?
Yes, it's visible.
Oh, okay. So
Yes.
the left side, consider it as a cell where it consists of solute molecules, this hexagonal and green circle, and this water. So suppose this picture is before vitrification. So after vitrification, what will happen is these molecules will be at the same relations to each other after thawing. But what happens in slow freezing is the water here, because of slow freezing, it will get time to form ice crystals and to nucleate and to become ice. Like the ice crystals will coalesce and form a ice. So this is the difference between vitrification and slow freezing. Here there is time for ice formation. Now the main disadvantages of cryopreservation system by slow freezing of human embryos were exponentially high expensive material to achieve freezing and the time factor. Now it's more practical slide. This is vitrification. Suppose everyone is aware that we have media like ES and VS. So ES is the equilibration solution which contains permeable cryoprotectants like DMSO and ethylene glycol that penetrate the cell. Now VS, that is the second solution, they contain both permeable and non-permeable cryoprotectants, hydroxypropyl cellulose and trehalose. Now upon exposure to non-vitrifying cryoprotectants, the cell immediately adjusts its osmolarity by losing water and strings. The cryoprotectants then enter the cell more slowly due to the low membrane permeability. The time of exposure to the non-vitrifying solutions at a defined temperature is of critical importance as it determines the intracellular concentration of cryoprotectants. So as we all know that for vitrification of blastocyst, we keep it around 15 minutes in ES, and then within a minute we wash it in VS solution. That is next. So that time is very important, because what happens is when the embryo is washed in a VS solution, there is still entry of the permeable cryoprotectants, and which may dehydrate the cell or increase the cellular concentration of cryoprotectants, which may be toxic. So that VS step is very important. Vitrifying solution may cause further cell dehydration, and which may increase the intracellular CPA. Similar to the oocytes will have a very low surface by volume ratio and low permeability to cryoprotectants, so they are less efficient. So the cryoprotectants are introduced very gradually during oocyte vitrification. These are certain advantages of vitrification, which is rapid. There is short exposure to cryoprotectants, the small volumes. There is no osmotic injury. It's a simple and cheap protocol. Some historical data, historical information, like initially these cryoprotectants were called as cryophylactic, and later it was renamed as cryoprotectants by Louet. Louet in 1964 coined cryobiology. In first pregnancy was seen in Australia in 1983 by Alan Tronson. 1998, vitrification came into the picture, first by Otai et al. Then in the same year by Vasta and Kuwayama, vitrification. Kuleshava reported the first birth of a healthy baby from a vitrified oocyte. Also, Chen did it in 1986. And the first vitrified ovarian tissue transplantation, first fertilization achieved was in March 2011 by Noriko Kagawa. And recently we are new vitrification by Kuwayama. It's called Cryotech. Then, yeah, thank you for this opportunity to the Synergy 4 Club. It's
Thank
open
you.
to questions. Yeah.
Thank you, Rahul. That was really, really, great and like a thriller sort of, a very high-tech lecture. And we came to know so many things. Of course, a few things, DMSO and all those things we knew. But tell me just a technical sort of question. You said the permeating cryoprotectants are all those chemicals, and the non-permeating are the sucralose and glucose and everything. So
Yeah.
those appear to be organic molecules. So these organic molecules do not permeate, and the chemicals permeate. How is it?
Uh,
I mean,
Actually,
yeah.
yeah. Basically, the difference between permeating and non-permeating is the molecular size. Like if they are smaller than 400 Daltons, then it is permeable. If the size of the oligosaccharides are more than 400 Daltons, it becomes impermeable to a cell membrane.
Okay.
So
So
it's
which
just the molecular size, nothing
so
chemical.
which
Yeah.
ones you think are better? The permeating ones or the non-permeating cryoprotectants are better? As far
No,
as
both
concerned?
both are important. Both are important. The main thing what the permeating cryoprotectant does is like in the equilibration stages, like 12 to 15 minutes, when we keep the embryo or oocyte in the ES, it will enter the cell. It will remove some water molecules, and whatever water molecules are left, this will form hydrogen bonds with those water molecules, which will make the cytoplasm more viscous. So the chances of uh, getting it frozen or to enter the crystallization state or the ice state is the very it becomes negligible if the cytoplasm becomes more viscous. And
Yeah.
what the non-permeating does is it lines the cell membrane of the oocyte or embryo. The permeability the permeability of cryoprotectants will be very slow, and uh, the main function of non-permeating cryoprotectants will be in the thawing cycle. What happens is when we do that TS and DS steps, what happens is because of this cryoprotectants, there is cellular dehydration. There is lot of water molecules will come out. So intracellularly, the salt ion concentration will be high. So suppose when during thawing, what happens if the embryo becomes like it's a collapse thing, it's a high salt concentration, it's very little water. When we introduce in thawing, where the solution is very hypotonic, like it's not so concentrated. So because of this high salt concentration, it will attract water inside the cell or oocyte or embryo. So to prevent this, there is this non-permeating will line the cell membrane. So what will happen, there will be a, as this decreases the cell permeability, slowly water molecules will enter the oocyte or the embryo. Because if this non-permeable cryoprotectants were not there, water would just gush inside the cell. It will just blow the oocyte or the embryo. So this non-permeating cryoprotectants will is of more importance in the thawing thawing state. Yeah.
Yeah, that's a very important point. So
Yes.
I think ideal vitrification for an embryologist would be one where all all the gametes and all the embryos, they survive the thawing process.
Yes.
You get 100% thaw. That is what you're targeting,
Yes.
So
Yes.
yes, so that is how technology should progress, and really very good. So tell me, why is it difficult to vitrify an oocyte as compared to an embryo? It's because of the size or the water content of the
No,
oocyte?
no, there is no difference in oocyte or embryo vitrification. The
Okay.
only thing is we'll have to introduce the cryoprotectant slowly to an oocyte because it's very sensitive. So there is only the difference that we just introduce the equilibrium solution very gently, like every 3 minutes we increase the volume. Other
Oh,
than that, there is no difference in the oocyte vitrification or embryo vitrification.
thank you very much, Dr. Rahul. That was a befitting ending to the, the flow of talks which were created by Dr. Kalyani and Dr. Ritu. And all three of you have really made vitrification very clear, like a textbook in front of all of us. And I think everyone attending the webinar has some carry home points which we can put in our practice. Thank you so much. And
Yeah,
I
yeah.
think Kalyani must be in the train right now, but thank you so much, Ritu. Thank you, Dr. Rahul. Thank you, Intas, and my studio partners, Intas, and especially Dr. Vishal Dave, who does the programs with me. And thank you, Nandini, Purva, and Neetu. Till we meet again, our next webinar is on 7th of November post Diwali, and we are doing gynec oncology. So till then, have a great Diwali and have a great weekend. Bye-bye. Thank you.
Thank you, ma'am. Happy Diwali, everyone.
Thank you. Bye-bye. Bye.
Yeah, Dr. Vishal, yeah, we had a little technical glitch. Sorry.
No, no, it's okay. It's okay.
It's okay.
It's okay.
Yeah, yeah. I don't know how it's.
Yes, yes. I also don't know.
Yeah. Fine. Okay, bye. Nice meeting you.
It was a good talk. I also understand. Basically, I'm gynecologist working as a
Yeah.
full-time medical advisor to Intas Pharmaceuticals.
Okay.
So I could understand your talk also. It's really interesting.
I don't know how much of this all the consultants might have.
The entropy concept really means I could understand what you are trying to tell. We don't directly it's passing one phase and directly going into glasses without
Yeah.
ice formation. Yes, yes.
Yeah.
That I could get what you're trying to tell.
Yeah. I
Thank
think.
you very much.
Yeah. Thank you for listening that patiently and focusing on that entropy point. Yeah, I really made an effort
Yes,
to like stress, but some of
Yes.
this delay, I think they got me on back foot for some time.
Yes, yes.
Right.
Thank you
Hello.
very much,
Okay.
sir. Thank you. Yes, you
Hello.
can end the meeting. Support team, you can end the
Okay,
meeting.
sir. Yeah, sir. Thank you, sir.
Thank you, Rahul, sir.
Yeah.